So hello, everyone. This is your host, Susan Rosen. And today I have Dave Sherazi back to talk a little bit more on some of the issues around, we had talked about sleep, and now we're going to talk about some pain and chronic pain types of issues that people have, and particularly having to do with affecting their sleep and any other issues, it just kind of takes over your life. I know with other people who've had it. So welcome, Dave. I'm really happy to have you back.
Wonderful to be back. Thank you for having me.
Yeah. So why don't you give me a little intro and the folks a little intro.
What I think is like the greatest kind of segue is a doctor decades ago, I want to say almost 50 years ago, wrote a paper called TMJ, The Great Imposter. It's kind of hard to find now, but you will find it if you Google search it. And he talked about, I think he was an ENT. He talked about a TMJ disorder can mimic so many things, right? So obviously, I think we talked about last time how people who clench their teeth get tension type headaches, which can then lead to migraine type headaches. But also, like the number 2 cause of a lot of ear problems, like ear pain, ear congestion, stuffiness, and even tinnitus. Right?
Interesting, yeah.
And usually, like when I say number 2, because number 1 is infectious, right? If you have a infection in your ear, that can cause a myriad of problems. But if your ENT has ruled out any ear issue, and you're having, let's say, tinnitus and ear congestion, etc., they should send you to someone who's an expert at working on TMJ issues in a functional way. So, for example, there are some experts whose their main methodology for treating a TMJ problem is, muscle relaxers and anti-inflammatories, which is fine for a very temporary period while you figure things out. But that's definitely not a long-term solution, right? You want someone that knows how to manage the jaw and what you do with it when you're clenching your teeth, let alone your bite. So that's something you want to be clear on what you want to find. With tinnitus, in my experience, because tinnitus could be even caused by acoustic neuroma, so you want to have an MRI and rule that out. But just anecdotally, just from like years of clinical practice, which is like 15 now, limited to this, is that if someone has the kind of tinnitus that comes and goes, right? Or maybe it's always there, but it sometimes gets louder, quieter, higher pitch, lower pitch, but it's not related to how quiet it is or how loud it is outside. Those I find can be related to a TMJ problem, and I'll explain in a second. But if someone has constant tinnitus that's always the same, never changes pitch or tone, and usually people that have that have a history of working with power tools, working with like high music, concerts and things like that, volume. So those are typically not related to a TMJ problem. This is just a very anecdotal, just sort of like heads up, but let your expert roll it out. We actually have a ligament from the TMJ that attaches to the malleus of the ear.
What is the malleus?
The malleus, so you've got 3 small little bones in the ear that are associated with sound.
Yeah.
And the malleus is like the 3rd one. And there are ligamentous connections because it comes from the same brachial arch during embryological development. So they have fibers that connect it, right?
Oh, okay.
So there is a connection. It's called the discomallear ligament, right?
Okay.
And if we have a clicking or popping in the jaw, usually that means the joint is in a different location than it normally is. And when it's like that, it'll pull on that ligament onto the malleus of the ear and can potentially cause tinnitus.
Oh, okay. I didn't realize that. Yeah, I get the clicking.
You get the clicking. Yeah, it could be associated with that as well.
Yeah.
Absolutely. So yeah, that's the correlation there. I don't know if we talked about it last time, but there is a phenomenon called central sensitization,
Hmm.
which is basically when we have pain, we have peripheral pain, meaning you stub your finger, you stub your toe, and you feel pain, right? Central sensitization is when that same pain is just re-injured over and over and over again. Yeah. And when it's injured, the brain actually goes or can go through plastic changes. It actually changes itself. And that's called central sensitization. And it makes other parts of the body hurt or react in ways that it wouldn't have before.
Interesting. Okay.
Right. So migraines, all migraines that I know of are centrally sensitized trigeminal disorders, all of them.
Okay.
Right. And there are, I think, a countless number of case studies where someone with migraines had their TMJ, who also had a TMJ disorder, treated their TMJ disorder, and the migraine went away. You know, I've even treated patients on several occasions that had what's called menstrual migraine. Like they get the migraine right before their period.
Yeah.
And very obvious a hormonal imbalance, right? It's a menstrual migraine. But even they also had a TMJ problem, and we helped treat their TMJ problem, and their migraines went away as well.
Oh, interesting. Okay.
Right? Because even though the hormonal problem surely wasn't resolved yet, it did something to the amount of impetus that went into causing that central sensitization.
Right. It kind of piled on.
That's right.
In a way, and made it. Yeah.
Yeah. So
that
you
makes
could
sense.
have the migraines from your TMJ and your hormonal imbalance.
Yeah. And maybe the hormonal imbalance wouldn't have ended up in a migraine if it didn't have this other part with it.
Correct. That's what we think. That's what we think.
Okay. That makes sense. You know, because there are different levels of pain, right? And if it can add together, and you know, the two things together make a bigger third.
Yeah. And you know, you have to think, one has to think, what is the benefit of central sensitization, right? Like, why is that evolutionarily ingrained in us?
Yeah.
And I mean, and these are all hypotheses, right? One, we could say, well, if you never treated the original cause, now your body has something else to remind you to fix it. That's also pain. That's one way. But if we look at things from the concept of survival, because our neurology, our body, our autonomic nervous system is geared towards survival, right? Both in the short term and in the long term, but mostly in the short term. The things that cause central sensitization or plastic changes in the brain are one, PTSD.
Okay.
Right? You know, traumas can cause plastic changes in the brain, and pain. Those are the only two I know of. Okay, outside of cancers, right? Those are the only two that I know of.
Okay.
But also, our pain receptors in our brain are tied in with our limbic system, which is our emotional system. Right? And also, like if a child gets a boo-boo and mom goes and like kind of like pets it, that actually works. That actually works. We have a motto that says proprioception blocks nociception, which means nociception is pain, and proprioception would be like the tactility. This actually blocks pain temporarily, right? That's why, if you notice, if you ever had a shot at the dentist, he'll jiggle your cheek right before he do the shot. Right. He's using proprioception blocks nociception gates there.
Okay.
So
I always wondered about that.
Yeah. So there is an emotional component there, but think about this. You know, when humans first came on Earth, first evolved on Earth, you're, you know, a family member, right? Let's say a parent and a child, let's just say, are eating food like berries or an animal or whatever. And while they're doing it, one of them has an anaphylactic response to a poisonous herb. Let's
Okay.
just say,
Yep.
hypothetically,
Yep.
right? And then that's it. And then that family member no longer has that family member in their lives anymore, which would be the closest to a PTSD outside of being chased by
Yep.
wild, right? And so that trauma can make someone now be more vigilant when it comes to food, right? Because early mammals, they were indiscriminate about the food they ate. They just thought, oh, food, I'm going to eat it all. Oh my God, more food, I'm going to eat it all.
Yeah.
Right?
Yeah. Yeah.
And only when they get to a point of like bursting does the concept of saving it for later come in. But usually mammals, early mammals would just
Right.
eat until they exploded.
That's right. Yeah.
So then now you have more advanced mammals that would eat and observe the person next to them passing away. And then next time they're going to go into it and go taste it, before they go and jump into eating it, right?
Yeah.
And then now imagine, now that person has now made epigenetic plastic changes to their pain due to their PTSD, right?
Yep.
Now, let's say they produce an offspring that had the same exact trauma, right? Now there's a strong likelihood that the offspring will have those kind of built-in mechanisms in their brain already built in.
Okay. No,
And then,
that's right. Yeah.
and then the next generation and so on survives because they became more vigilant about what they ate because of what happened in the past.
Yeah.
Does that make sense?
Oh, no, absolutely. That's the learned behavior, and the learned, that is just goes on and on from generation to another, from one to another. Yeah. No, it makes perfect sense.
Yeah, it just came to me as I was driving to work one day that, that's really something else, that could have been the direction and the purpose of central sensitization. We don't know, the hypothesis, of course.
Yeah. No, absolutely. And there's so much about how humans developed, along with all the other animals, that we still don't know. I mean, it's just having not been there. It's kind of hard. So much of what everything that we're educated with, right, is a lot of it's just guesswork. It's just
it is. But in looking at the big picture, though,
yeah, it's like what makes sense, what fits the picture. Yeah,
what fits the picture. And of course, the first thing, again, if you focus on survival,
right,
a group of people have a higher chance of survival if they stick together.
Absolutely.
Right?
Absolutely.
If they distribute their food, if they protect each other more evenly, they have a higher chance of survival, right? But at the same time, different groups of people in this, held in a relatively small space have an opportunity to have conflict, right?
Yep.
But the interesting thing is, if you study psychology, knowing the conflict, things that trigger us will help reveal what we have going on inside of us. Right? So it depends on how the individual takes it, but just being around other people can be enlightening in and of itself.
Yeah, no, that makes sense. Sense. Again, learned behavior, right?
Learned behavior. And because the truth is that everything, without exception, everything is a neutral event until we decide that it's good or bad. Right? There's always going to be what we want and what we don't want, but everything is a neutral event.
Yeah.
Right?
Yeah.
But if something goes from being a neutral event to being a trigger, then it's like, okay, well, let's talk about the trauma of that. What brought on the trigger? The trigger comes from within, not from the external.
Right. Yeah. No, absolutely. And aren't we lucky that we have words to describe that? because our ancestors didn't.
They sure didn't. No, they did it the hard way.
Yeah, yeah, no, you know, and I think the other part of that is, or the negative part of that is that we as human beings really go down a lot of rabbit holes, right? Talking about things and describing things and putting things together that yeah, maybe some of them should be together, and other ones are like, well, no, that's a little out of the out of the range of possibility.
Totally. Totally.
Yeah, so it is so interesting to see how things do change and morph as we and other animals change and morph.
Absolutely.
Yeah, very interesting. So back to like the chronic pain. Maybe we can talk about that a little more specifically. I know you've made the connection, right,
Sure.
with a lot of the TMJ, but then what do we do about it? Right.
Well, that's the challenging part, because someone that has acute pain, like new pain, it's almost always from where it hurts. Okay. When someone has chronic pain, it's almost never from where it hurts.
I didn't know that. Okay.
Because of that concept of central sensitization, that mechanism of central sensitization. So a physician, he's passed away, but his name was John Beck, certifiable genius, this man, just a brilliant human being. And he was an orthopedic surgeon working on workman's comp cases out here in Anaheim, in California. And him and his partner had noticed that they had a really poor success rate, and they couldn't understand why, because they knew the how the injury happened. They saw the videotape of the injury oftentimes. They did the MRI, they saw the problem, and they had physical therapists, they had surgery, they had all these things at their disposal, and they had very questionable, outcomes, which like everybody did, right? So when the concept of central sensitization first came up, only in 1989, it was published in the journal Nature. It's a pretty new concept, right? Very few people actually understood it, but they did. And they came up with a neurological exam that they named. They have a lot of names for it, but motor reflex test is one. Pain, PANE, is one. They published at least 4 times, if not more. And they were able to determine what the hierarchy was in the concept of pain. Right? So, like, my mentor would follow him for a year. And for a year, like 1 day a week, he would just follow him. And a patient would come in and would complain about left median nerve pain. And he would examine it, and then he would do a motor reflex test, and the patient tested for right median nerve pain. So then all he did was examine the right side, and the patient would say, "Doc, it's my left side."
Right.
And he goes, yeah. So he examined it, and then without asking permission, he would just pull out his pen and just do a lidocaine injection on that right side, right? And the patient's like, "Well, what are you doing?" Right? But he was a very likable guy. So, he would be very chatty with his patients. He was likable. And he goes, "Well, I'm doing an experiment. Let's see." So he gave it about a minute or two. And he goes, "Okay, how does your left side feel now?" And he goes, "You know what? It doesn't hurt anymore." He goes, "Yeah, it's the right side that's a problem." Right? So then he would order the correct MRI. He would order the correct surgery or physical therapy or both. And patients would get better. Right? And that's the thing. And so now there's other orthopedic surgeons out in like Indiana and such that are using this motor reflex test to find out what the cause of the patient's issues are. And every center, I told you, I'm in a group. There's 65 of us throughout the world. We all do the tests. It's one of the most defining characteristics of our centers is doing this test and seeing
Oh.
if we can find the origin of the patient's problem. If we can.
Yeah. Yeah. No, that makes a lot of sense. Just because, I mean, there are also all those things about how people have they hurt their right leg. Okay. And so then they start favoring the right leg.
Right. And they
And
put all
the
the weight on
left hip and the left leg starts being out of alignment.
Yeah.
And and it just builds and builds and builds, right? So it all makes a lot of sense. It all makes the same, I mean, it's kind of the same idea.
It's a similar concept. Well, we definitely see that in the NFL. When someone blows out their ACL, it's usually within a season or two that they'll blow out the other ACL.
Yeah. No, you're right.
We see that.
Absolutely.
We see that a lot. Yeah. And I'll tell you, in my field, that I think that's one of the reasons why TMJ pathology has been such an enigma, because patients will come in and we're trying to find out what's the cause of their problem. And then once we find the cause, well, how do we treat it then?
Yeah.
Right. So it's been a challenge in our profession for sure.
Oh, I'm sure. Yeah. Yeah. Well, that's the alignment and all of that is a lot of what the chiropractors do, and a number of the other more hands-on physical kinds of
osteopaths and some physical.
That's right. Exactly. Yep.
Even some craniosacral people, but
yes.
osteopathic.
Oh yeah, I've had that. That's wonderful. Yeah.
It's obviously the greatest. Yeah.
Yeah. Just thinking about it makes me feel good. Well, I love having, well, most people do. I love having my head, massaged and,
No, when the osteopaths work on me, even the craniosacral therapists, when they work on me, I just go straight to sleep. I love it.
Yeah. Exactly. Yeah. Yes. Okay.
So other things like trigeminal neuralgia, or any kind of neuralgia like burning mouth syndrome or things like that, those are also centrally sensitized disorders. Right. And finding the cause to that is really, really important, because the alternatives, brain surgery and like medication are really not fun.
No, and can be dangerous, really. Well, maybe dangerous isn't the right word, but a lot more open to issues.
Yeah,
I mean, a lot of these other things that you should do first.
Yeah, risk, risk from surgery versus risk from wearing a removable appliance is quite different.
Yeah. Yeah, just a tad.
You're right.
Not to mention the cost.
Yeah. I had a couple patients that actually preferred surgery, and it surprised me. But you got to let them do what they want to do. All you can do is give them an informed decision and let them, decide what they want to do.
Oh no, absolutely. Especially when you're trying to get somebody to wear an appliance when they're sleeping, or even during the day, because if they're not going to do it, I know even myself, when I was growing up, I had orthodonture work.
You didn't wear your retainers?
Well, I would put them in, and in the middle of the night while I was asleep, they would end up on the floor or on the table next to me, or
that's
whatever.
That's not so uncommon.
Oh no, I'm sure it's not. Yeah. So that's why my top teeth are much straighter. They even didn't do anything with my bottom teeth.
Okay.
Yeah. I mean, they put one wire in it on the inside when they were growing out, but that was about it.
Yeah.
But it doesn't matter, because nobody can see my bottom teeth anyway. So I think that was the idea.
Yeah. And the way we treat chronic pain, like the kind of conditions we were talking about in children, in the growing child, is through what's called functional orthodontics.
Okay.
You know, because you can't make a night guard on a mouth or a maxilla on a child that clenches their teeth. You follow? So you have to make something for them that's going to either accommodate or support their growth.
Okay. Yeah. Well, yeah, because otherwise every couple of months you're going to have to do a new one, right?
No. That's the problem. Is if you make
no,
a night,
I'm saying with the night guard. Yeah, that's what I'm saying.
That's what I'm trying to say.
Yeah.
Is with the night guard, it would act like a retainer, so it would stop the growth in their mouth.
Ah, right. Okay.
Which of course you don't want.
I see. Okay. I misunderstood. Okay.
Yeah.
Interesting. That makes sense.
Yeah, and I've had patients that unfortunately had to do that, and they just have a teeny mouth. Just
oh no!
You could barely put their thumb in their palate. It's pretty tiny.
Wow. Yeah. Interesting. Huh. Yeah.
That's how I got into all this. Was I was doing functional orthodontics straight out of dental school, and I was really enjoying it. And both adults and children were coming and telling me, "Oh, my migraines are gone." And I would say, "Well, I didn't even know you had migraines," you know? And I said, "Good for you," and they're like, "No, when I take your appliance out, my migraines come back." Right. And so the first time it happens, I'm like, okay, that's just weird. And then it happened a second time. And, I take it to my study group and I take it to the lectures I've gone to. And they apparently knew this. Apparently it wasn't the secret that I thought it was.
But they hadn't shared it.
Well, not yet anyway. And because, it's big. It starts off, the concept gets bigger and bigger and bigger, but you can tie it together.
Yeah.
And when I got into the world of craniofacial pain and orofacial pain, boy, this was a world that was completely new to me. Like when I took these courses, it was nothing like the other courses I had ever taken for like root canals, extractions, fillings, whatever you want to call them. They were nothing like it. They were completely different. Completely.
I would think so. Yeah.
Yeah. And I was just blown away. I'm like, this exists. The concept, the specialty wasn't even mentioned in dental school.
Yeah.
We had rotations in ODNR, which was orofacial pain, oral pathology, diagnosis, and radiology. And we discussed pain a little bit, but it wasn't anything that went in depth.
Right. And particularly if it sounded like it was something in the head, but not even in the head sometimes, right? But not right around the mouth or the jaw or something, right?
That's right.
Because the powers that be would be thinking, oh no, that's outside of our
it
understanding.
And it's not that it's outside what we do, because our jaw is the foundation of our bite. Our muscles are critical to our function. But there's two aspects of dental studies that I've noticed. Is one, the health studies, right? So you can know whether what's going on with the patient and whether medications or anesthetics are okay. But a big part of the knowledge of dentistry is what I call in the carpentry of dentistry. Right? The prepping of teeth, the mechanical aspect, the management of soft tissue and hard tissue, the occlusal or the bite balance, like that's like the focus of the vast majority of dentists. And I'm not saying it's wrong. I'm just saying it's what it is.
Yeah. Unfortunately, society has kind of locked them out into a particular area. Just like they have with other doctors. That's why the chiropractors and the osteopaths and all that are naturopathic doctors are all able to deal with all these things that are kind of a little more edgy, if you want to call it that, and the connections much more than your typical MD.
Correct. Usually allopathic medicine from a conventional MD is more focused on symptom management, either with medication or with surgery. And osteopaths, chiropractors, and naturopaths are not always, are predominantly, are focused on more the functional cause of the problem. So they're going to go fishing.
Yeah.
See if they can find, a causal link.
Yeah. Which is why typically that's where I go if I'm looking for something more along those lines than than giving me a Band-Aid or something for
Yeah.
And that's it's my my MD doctors have always been it's like they listen to me when I say, well, can you do this and can you get me this kind of test and stuff, and they look at me and it's like, oh no, another one of those, right?
Yeah.
Sometimes they play along with me and sometimes they don't.
Yeah. They're doing the best they can. I always say
that's true, and the best they're allowed in a lot of places as well, right? I mean, like a just because the insurance companies or the medical places like Kaiser and things like that, I mean, that's just it's an institution just like anything else.
Yeah. Their hands are more tied.
Yeah. Absolutely. So back to with the TMJ, I know the last time we had talked a little bit about the appliances and that sort of thing. So is it mostly just that one that we've seen with the two, the top and the bottom, and then the metal kind of in between to train the tongue? I know you had showed that before.
Yeah, no, it really depends. Like we have an alpha appliance like we talked about.
Okay.
That's the more orthopedic movement. Okay. We have different appliances to treat sleep apnea or to manage someone's what we call bruxism, their clenching of their teeth. But that's about the extent of it. When we talk about like TMJ disorders, we're trying to find, so how did they get here? And a lot of times it's just because they clench their teeth. It could be a whiplash, or could be other things, other factors, could be their bite. But we're always just trying to find the cause and treat to that.
Okay. Yeah. No, I know I have my little thing for clenching my teeth at night that I wear. But yeah, I get the clicking and the, and it gets out of joint, and
and we've had like last time we talked about how at roughly 50% of the time it's a form of sleep apnea that is related to clenching of their teeth.
Yes.
Right. So we have to sometimes go in that direction and let them know, hey, this is something you may want to talk to your physician about, putting a sleep study and treating that.
Right. Yeah, exactly. No, we had talked about that. And actually I forgot to mention that to my doctor when I was there a couple of weeks ago. As a matter of fact, I had my little list, and I keep finding things that I forgot to write on there. But yeah. Well, it's for me at least, it's developed more so as I've gotten older, because I wasn't snoring when I was younger.
That's typically the case. It's usually a progressive problem.
Yeah.
The neuromuscular tone gets weaker as we get older. Usually, we don't use it.
Right. Oh, no, exactly. Exactly. And so, yeah, I've been trying to sleep on my side,
Okay.
or which I don't snore when I'm doing that. So that's a good thing.
Mhm.
I couldn't do that for a while because I had a shoulder problem.
Okay. Yeah, I
Yeah.
remember.
Yeah.
Mhm.
Yeah. 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 So it's been good. I've been able to sleep more on that way. And I have found that that I am sleeping better.
Good.
Yeah.
Yes. Excellent. I love that.
Yeah. Yeah.
That's
Yeah.
global on everything.
And my husband's sleeping better as well.
Yeah. Yeah. The secondhand snoring is a real thing.
I know, now I only have to deal with his, but that's a whole nother issue.
That is a whole. Yeah.
But anyways, okay, well, why don't we is there anything else that you'd like to kind of bring this all together and let people
Yeah.
know maybe what to look for and maybe who to talk to, and that all that sort of information? I know we talked a little bit about it the last time, but I think it'd be good to repeat.
Yeah. Yeah. So on my website, TMJLA and
Mhm.
TMJ
Which I
Conejos,
will put in the show notes. Uh-huh.
sure. There's a lot of information on both pain and sleep
Yes.
and the different ways that you can have it evaluated and checked.
Yeah.
There is a website called tmjtherapycenter.com,
Mm.
and center is spelled CENTRE, like the British
Right.
way.
Mhm.
And they have a resource page for, obviously, if you're
Yes.
not in the LA area, they have
Yeah.
resources where you can go to places so you can find someone near you that does what we do.
Yeah. 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 No, exactly. Although when you get to certain areas, there aren't very many, because I was looking in there. I mean, up here it's fine. There's somebody in San Francisco, which isn't that far away. It's a pain to. He's in a medical building, which it's a whole other issue as far as
Yeah.
parking downtown San Francisco. But but other than that, I know there was someone I was looking for in Wisconsin, and there is somebody there, but it's in some small town, and the people I'm looking for are in another small town. They're not even close. It's like 80 or 100 miles away.
Mm.
So yeah. So I don't know if there are other. Is there something else that people can do a search for as far as particular words that might bring up something that might be closer if it's
Um, I mean, you could just try the word, even though TMJ specialist doesn't exist. You
okay?
could you could Google it, and something
Uh-huh.
will come.
Yeah.
Mhm.
Okay, that's what I was thinking. Okay, good.
Mhm.
Good. Well, we'll try. I'll tell her to try that.
Yeah.
Yeah. Yeah. No, that would be great. So
Well, great.
okay. And is there any other thing other than just to tell people to pay attention to whether they are starting to snore and having those kinds
Well,
of issues?
do something with your sleep. It's the most important thing. So,
Mm,
when going to bed, make sure your bedroom is dark and
mm,
cool, and your bedroom is only used for sleeping and sex. There's no
hmm.
eating. There's no family time. There's no
Yeah.
work done in the bedroom, and just make it a sacred space just for sleeping. Yeah. And that'll go a long way. We call that sleep hygiene. That'll go a long
Okay.
way. Make sure your phones are either totally off or on airplane mode.
Hmm.
If you can keep your head away from electrical devices, that'd be great. Even electrical outlets, that might be a benefit.
Ah. Hmm.
Mm. Just be mindful, like little things of light, like sometimes TVs, which I don't have a TV in my bedroom, but sometimes TVs, even when it's off, there's that one little red light,
Yes.
right? That
Hmm.
does mess with you.
Interesting. Interesting. Yeah. Yeah. Well, and there's also the whole thing of when the sun comes up in the morning, especially on
Hmm.
these long days,
Hmm.
and it comes up an hour or 2 hours or 3 hours before you get up.
Hmm. Yeah.
And
Make
and
sure the
that
room is
can,
dark. Hmm.
yeah,
Absolutely can mess with your circadian rhythm for sure.
yeah, yeah. Oh no, exactly.
Thank you.
Yeah.
Thank you for bringing
So,
that up, and thank you again for having me.
oh, I really appreciate it. I I can identify as you can tell
You
with
can
a lot
relate.
of the information. I can definitely
Yeah.
relate. Yes, yes, for
Okay.
sure, for sure. So, okay, well, thank you. And let me just say my usual little spiel at the end, which is that this is not to be seen as specific medical advice.
Right.
And your best bet is to try and find somebody who you can go to or talk to about this information or any of the issues that you're having
Mhm.
around this whole subject.
Mhm.
And for sure, check out Dr. Sherazi's website because there is a lot of information on there. I can attest to that.
Thank you.
So that's it. And I will talk to you all. Nah, if I could talk, I will be talking with all of you guys next week.